Dear viewers, please be welcome at this e-seminar organized by the ERACODA research group on behalf of the European Renal Association. And you are joining an e-seminar that is one out of a series dedicated to kidney-related aspects of COVID-19. And in this series, we are going to cover 3 different topics. 3 weeks ago, it was dedicated to chronic kidney disease patients and their high risk for a severe course of COVID-19. And today we will be discussing acute kidney injury caused by COVID-19. In 2 weeks from now, on December the 17th, and I invite you to join that session, we will conclude with an e-seminar on practical COVID-19 related aspects of kidney replacement therapy. For instance, how to organize your dialysis units optimally to prevent transmission. And as I told you, this series of e-seminars is organized by ERACODA. And let me first introduce you what ERACODA means. ERACODA is an acronym and it stands for European Renal Association COVID-19 Database. This database was established in March this year by the ERA-EDTA Council to collect prospectively granular data of patients on dialysis or living with a kidney transplant that developed COVID-19. And we have 2 aims with this database. First, to investigate the clinical cause and outcomes of patients on kidney replacement therapy that have COVID-19. And secondly, also to gain information on risk factors for mortality, because such information, we hope, may guide clinical treatment decisions, support triage strategies for instance, for admission to intensive care units, but also lead to interventions. And per December 1 this year, we have now data on more than 2,200 patients with kidney failure and COVID-19, and approximately 70% dialysis patients, 30% transplant patients. And these data have been entered by more than 200 nephrologists working across Europe. And we are very grateful that these people are helping us with the database. Let's go to today's program. I realize I haven't introduced myself yet, but I am one of the 2 moderators of today. My name is Ron Gansevoort. I'm professor of nephrology at the University Medical Center Groningen, the Netherlands, and I'm one of the coordinators of the ERACODA study. And our co-chair today is Professor Luuk Hilbrands from Nijmegen, the Netherlands, and leader of the kidney transplant work package of ERACODA. And today's program has 2 topics. The second one will be about mechanisms how the SARS-CoV-2 virus causes acute kidney injury and therapeutic implications. But we'll start with the epidemiology of acute kidney injury in COVID-19 and clinical consequences. And the presentation will be given by Professor Nick Selby, Professor of Nephrology at the Nottingham University and consultant at the Royal Derby Hospital in the UK. I'm very glad that Nick, that we have him as speaker, because as you may know, he has published on this topic, and he was also involved with writing the NICE guideline on COVID-19 induced acute kidney injury. After his presentation, there will be a 5-minute comments by Professor Eric Hoste as a panelist. And Eric Hoste is Professor of Medicine at the Department of Intensive Care in Ghent and also head of the Transplantation Center there. So he will open the discussion with some comments and questions, and thereafter there will also be a possibility for the entire audience to have questions and answers. Let's go then to the first presentation, and please, Nick, go ahead.
Okay, thank you very much. Can you see my screen? It doesn't look like it's sharing correctly at the moment.
Perfect, Nick.
It's okay, great.
Yeah.
Okay. Brilliant. Well, thank you very much, Ron, for the kind introduction. It's a great pleasure to be taking part in the webinar this evening, and also to be asked to talk about the epidemiology of COVID-19 associated AKI. So this slide gives an overview of what I'm going to talk about, and I'm going to address the topic by trying to answer these questions. Firstly, what proportion of COVID-19 cases are complicated by AKI? Then talk a little bit about who is at risk and when does AKI occur? Which people need renal replacement therapy, and then what are the outcomes of AKI in the setting of COVID? The causes of AKI, the question about why people get it, that will be covered in the following talk by Tobias. And then I'll finish by discussing some of the patterns of AKI that we're seeing now, and asking whether the epidemiology of AKI in COVID is changing, and then speculate as to some of the possible reasons for this. So if we start with the first of these questions, what proportion of hospitalized patients with COVID sustain AKI? I think it's fair to say that there's quite significant variation in the reported rates of AKI in the literature. At the extreme, that includes misleading reports such as this one from China at the beginning of the year. Reports saying that AKI was extremely rare or didn't happen in patients with COVID-19. And data such as this we now recognize as false, because clearly AKI is a significant complication. And so what about more realistic numbers? Well, this is a systematic review, and it pulls together results from 20 different studies. And I think results here give a better picture. So in the 20 studies that were included, 13 were from China, 1 was from Korea, 3 from the US, and 3 from Europe. And in total, over 13,000 patients were included. And pooled analysis of data from these studies suggested that the overall proportion of patients hospitalized with COVID-19 who developed AKI was 17%, so still a significant proportion of cases. And 5% of patients went on to require renal replacement therapy. But underlying this, there's still significant variation in the reported rates. And the authors demonstrated in a sub-analysis that the studies conducted in China in particular had very high heterogeneity when analyzed together, particularly compared with those from Europe and from the US. And if you just look at the studies from the US and Europe, then you can see that that broad range narrows in at both ends and gives a clearer picture maybe. However, there are a number of other factors other than just region that might explain differences in reported rates of AKI. So that includes differences in AKI definition. Not all studies, for example, used the KDIGO definition to describe AKI. There may be different practices in patient testing, and also different thresholds for hospital admission, for example. But probably one of the biggest factors that explains variation is to the extent in which critically ill patients are represented in these cohorts. And you can see across these 20 studies, the proportion in the group that were in critical care varied significantly from 13 all the way up to 100% of the cohorts. And it's very clear that AKI rates will be higher in critical care. And just to emphasize that point, this slide shows the reported rates of AKI in COVID patients in ICU populations. 3 studies from the US, but consistently reporting AKI rates of above 60%. So I think when evaluating the incidence of AKI in patients with COVID, it's really important to determine the proportion of critically ill patients that are included in the cohort that's being described, because clearly that will have a big effect on the reported rates of AKI. And if we now look at one or two of the studies in more detail, that allows further granularity around the question. So in this study, a retrospective cohort study from New York, the authors identified all patients who were hospitalized and tested positive for COVID across a group of 13 New York hospitals in approximately a 1-month period. And that resulted in a large cohort of almost 5,500 patients. In that group, the authors used the KDIGO definition, or at least the serum creatinine components of the KDIGO definition, to identify acute kidney injury, and saw evidence of that in almost 2,000 patients, or 37% of the cohort developed AKI. About half of this was AKI stage 1, and about half was severe AKI, so AKI stages 2 and 3. And certainly this is more robust data supporting the conclusion that AKI occurs frequently among hospitalized patients with COVID. But is this any different from AKI in any other acutely unwell population? And I think the answer to this question could be yes. This study, this is an analysis from our group. The analysis was led by one of my colleagues, Nistin Kohli, and we were able to include a non-COVID group, so hospitalized patients who tested negative for COVID. And we were able to look at AKI rates in these patients alongside a contemporaneous cohort of patients who did have COVID. And whilst accepting that these groups weren't perfectly matched at baseline, so the COVID group had more comorbidity, more males, for example, you can see that there is a much higher rate of AKI in the COVID group, more than double in the COVID group. And that's probably more than can be explained just by baseline differences. So these data support a conclusion that AKI rates were higher in hospitalized patients with COVID as compared to other non-COVID hospitalized groups. And alongside creatinine-based definitions of AKI, high rates of urinary abnormalities, so hematuria and proteinuria, have also been reported. In this retrospective single-center study of Chinese patients with COVID-19 pneumonia, of the 3/4 of the group who presented with renal complications, the majority had hematuria and proteinuria rather than AKI. And similar reported rates of urinary abnormalities have been seen in other studies from New York, from New Orleans, and also from different Chinese centers. So, moving on to the next question, what about patients and can we tell which patients are at risk of AKI? So if we go back to the New York cohort study that I described previously, they identified a number of independent variables that were associated with the development of AKI in their COVID-19 cohort. And they separate into 3 groups, really. The first is demographic factors, so increasing age. Ethnicity was important, with higher rates in Black ethnic groups. The second group was the presence of chronic conditions, so diabetes, cardiovascular disease, and hypertension. And then the third group were markers of severity of the acute illness, so requirement for vasopressors, but in particular, a very strong effect and a strong association with the need for mechanical ventilation. And in the cohort from our center, we saw, again, a very similar pattern there. Those same 3 groups: increasing age, presence of comorbidity, and in our analysis, particularly the presence of pre-existing chronic kidney disease. And then thirdly, sicker patients. And again, seeing that very strong association around the need for mechanical ventilation associating with the onset of acute kidney injury. The second part of the question of risk is to do with time. So at what time point during the course of illness with COVID-19 does AKI most commonly occur? And again, there is some variation in the published literature here, but the data shown here, again from that New York cohort, suggests that there's two peaks in incidence of AKI. The first is around time of admission and within the first 24 hours. Overall, there's a higher rates of hospital-acquired AKI than you might normally see. But then there's a second peak at day 8+. And this associates with patients who are then clinically deteriorating, for example, developing secondary sepsis. But again, a very strong association with the need for mechanical ventilation at that time point during hospital admission. And the clinical relevance, of course, is that vigilance for AKI must remain high throughout the hospital admission for these patients. And that's important not just from us, from a nephrology standpoint of view, but we also must get that message out to our non-nephrology colleagues who are caring for these patients on the COVID wards. And without straying into the topic of the next talk, acknowledging that there are different causes of AKI in COVID-19, if we look at the question about which patients need renal replacement therapy, then the vast majority of these sit within critical care. The number of patients with single organ renal failure are very, very small in comparison to that. And whilst I've shown you some data already about the rates of AKI in ICU, this slide shows the rates of renal replacement therapy in 4 different ICU cohorts. So 3 cohorts from the US, but also the UK National ICU audit. And again, showing pretty consistent picture of renal replacement rates in ICU patients with COVID of around about 25 to 30%. And I think it's important just to state that all of these data are from the first wave of the pandemic, which we'll come back to later. And whilst it's not strictly epidemiology, I think it's only right to acknowledge the huge strain that this puts on the healthcare system, both also on the supply chain and resources within healthcare, and also the people working within these systems. And really, this situation was driven by a perfect storm of increased demand for renal replacement therapy, which was a combination of a large patient cohort, so all of these patients presenting at the same time, higher rates than we'd normally see of AKI-D or AKI requiring dialysis, and then at the same time, increased use of renal replacement therapy consumables, so issues with coagulopathy and lost circuits, so burning through consumables that way. But also from practices where we needed to try and maximize the patient to machine ratio. That also resulted in increased consumable uses. And just as a statistic to show the scale of the problem, in England, between April and August, there were over 38,000 RRT treatment days delivered. So vastly more dialysis being delivered in critical care than we'd normally see. And to deal with these challenges, we've had to adapt. And in many cases, this has led to closer working between nephrology and critical care, which was essential because in some places and at some times we had to broaden the model and increase the range of RRT modalities that could be used. And so in the UK, for example, this was a shift from almost purely continuous renal replacement therapies in normal ICU practice to increased use of intermittent hemodialysis and SLED. And even some centres effectively use peritoneal dialysis. And I think this approach has also brought benefits as well as challenges, both locally, but also on a systems level. And maybe as a community, this is something that we should be examining and supporting and trying to sustain some of the good things that have come out of this necessity. Okay, so if we go back to the sort of remit of my talk, the epidemiology, what about the outcomes of COVID-associated AKI? Well, again, it's obvious that outcomes will be worse in patients who develop AKI. And that's shown very clearly in the pooled analysis from the systematic review that I showed you earlier. So the odds ratio of mortality in COVID patients who developed AKI was increased over 15-fold. And interestingly, that risk did seem to differ a little bit depending on whether you were in an ICU or non-ICU setting. The association or the effect size with mortality was particularly striking in critical care settings, although a 10-fold increase in mortality is not to be ignored in the general population, who actually numerically may be the larger of the caseload. And almost all of the data that I've shown you so far has been from the first wave of the pandemic. And of course, it's obvious there's going to be a natural publication bias towards studies from earlier on in the year. But I think both our clinical perception, but also some evidence from the data suggests that patterns are changing in the second wave of the pandemic. The data on this slide are from the UK national audit, the ICNARC audit. And they show data from the first wave of the pandemic, so data up until the end of August this year. And then alongside that, more recent data. So these are from ICU admissions with COVID from September onwards. And the red blocks are just highlighting the data around renal replacement therapy. And you can see in the second wave, there's a much lower proportion of patients requiring renal replacement therapy. So about 10% as compared to 27% in the first wave. And they're needing it for shorter periods of time, a median of 4 days as compared to 8 days at the beginning. At the same time, there may be a small shift in severity of acute illness, but other practices are changing. So we can see a big reduction in the rate of invasive or mechanical ventilation within the first 24 hours of ICU. So practice changes such as this may have a big impact on AKI and therefore in turn on renal replacement therapy. There may be other factors at play too. So better awareness of AKI in general. More guidelines are now published and are more easily accessible. Education initiatives such as this one may all play their part. And we've also seen clear changes in practice. For example, a move away from the practice of running patients very dry that was commonplace at the beginning of the pandemic, which I think we now know is not helpful, and I think which may have accounted for AKI at the beginning of the pandemic in some cases. Then, of course, there's the effect of treatments, and we're all very familiar with the positive results from the recovery trial in which dexamethasone showed a clear benefit in terms of mortality. And this slide is showing the impact of some of the interventions tested in the recovery trial on the rates of renal replacement therapy. And you can see that hydroxychloroquine and lopinavir, ritonavir had no effect here, a bit like their results for the overall endpoints. But you can see a very promising effect of dexamethasone. So a big risk reduction, a 37% reduction in relative risk in terms of renal replacement therapy in the intervention group. And moving away from direct clinical issues, there may be something also around the data and how we look at that. And it's been difficult to keep abreast of all of the information coming out over the last 10 or 11 months. And I think there's been fluidity in both the volume, the quality, the types of study that we're seeing, and also variation in results between different studies. And so our understanding has sometimes changed and had to change significantly in response to this data. And there are different examples of this, but I just want to sort of illustrate that point with one example using the extremely valuable ICNARC data that we had from almost the beginning of the pandemic in the UK. So the graph here is showing the percentage of survival in ICU patients requiring renal replacement therapy. And initially, survival at the beginning of the pandemic looked very low in these patients, which sparked concern in some quarters. But actually, the explanation is not a clinical one. It's to do with the data, in that the early reports were overrepresented by those who did not survive and had shorter ICU stays. And those patients who survived, but often with long ICUs, ICU stays were only included in later reports. And so that the better and the more representative survival rates that we saw later are really an effect of better quality data at that stage. So understanding the data is crucial. And so my final slide is one area in which we have very little data, but could potentially be a significant long-term challenge. And that's the effects of COVID-associated AKI on the risks of chronic kidney disease and long-term risks of end-stage kidney disease. Some studies suggest that there are high rates of unresolved AKI at time of hospital discharge, so around about 50% in these two studies. But at the moment, we have very little data that goes beyond that. On the other hand, some of the urinary abnormalities that are reported appear much more transient. So what all of this means for long-term CKD rates is not yet known. And this problem may also be compounded if we're relying on serum creatinine and estimated GFR, which may be affected in patients who've lost muscle mass, and therefore this problem could potentially be underestimated. So I'll close there. Thank you very much for your attention, and I'll try and summarize what I've said in two groups. What we know is that AKI is common in hospitalized patients with COVID-19. There are very strong links to critical illness, and there are high rates of renal replacement therapy. And as with AKI, in most situations, outcomes are worse in those patients who develop it. However, a number of uncertainties remain, and our understanding continues to evolve. Look at the data carefully, because different sources are of varying quality. And I think we also are seeing changing patterns of disease in the second wave of the pandemic. And at the moment, we know very little about the long-term effects of all of this. So thank you.
And thank you, Nick, for this excellent and very clear presentation. And during your presentation, you stressed that there should be good communication between nephrologists and intensivists. And in that respect, I think it's excellent that as panelists, we have an intensivist. That's Professor Eric Hoste from Ghent in Belgium, who will start giving us some comments on your presentation. In the meantime, I would also like to invite the audience to send in questions they may have to Professor Nick Selby on whatever topic about the epidemiology of acute kidney injury in COVID-19. And then Eric, please go ahead.
Thank you very much for having an intensivist in the room. I started off with a kind of a summary of my take of your splendid presentation, Nick. I've done also some research on epidemiology in COVID, and it's true what you said. I had the same experience. There's an enormous amount of papers, and there's also an enormous variation in reporting on the definition of acute kidney injury and on the definition of COVID. There's varying timelines for endpoints, so it's very difficult to get a grasp on this, and this probably makes it so difficult to tease out these epidemiological data. So that's a plea to, as long as my plea is to use KDIGO definitions and use the normal endpoints we all use in other studies, 30-day survival and even longer. So that's one thing. Of course, another thing that's difficult to manage is the inclusion bias. We were overwhelmed, and people couldn't enter the ICU where in normal times they would be in the ICU. So that's also introducing a bias in the epidemiological data. But that we have to deal with that. What's striking to me is that when you look in AKI ICU literature, urine sediment is hardly discussed. But in COVID AKI, it's very prominent, and so we now know that that there's hematuria, there's proteinuria, and I'm not sure how this relates to other ARDS-related AKI patients. Maybe you can elaborate on a little bit on that, and it kind of suggests to me that the kidney abnormalities are different from what we're used to, and also the data you've shown in your study comparing ICU patients with COVID and without COVID, and all the other studies suggest that the incidence of AKI is quite high, and the incidence of need for or use of renal replacement therapy is quite high. So kidney involvement is very prominent in these patients. So that's intriguing for me. So what are the implications on long term? You hinted a little bit on that, this probably asks for some follow-up, and maybe we should organize ourselves on that, because it's I think there will be another pandemic coming up, or I fear there will be another pandemic coming up, patients developing chronic kidney disease. Maybe I'm wrong, but we should be thinking about that. So maybe my first question would be, what's your take on long-term follow-up? How would you organize this?
Well, I think it's a really important point, and I think we need to understand more, and at the same time we need to think about how we might sort of need to operationalize follow-up in a scenario where we don't have all the answers at the moment. And I think to sort of answer to the first question, there are studies ongoing looking at sort of the long-term effects of COVID, and I think we sort of look forward to those sort of studies. But I do worry that many of these studies aren't focusing primarily on the kidney. So quite rightly, it's on respiratory disease, and then maybe on cognitive function, maybe then on cardiac function, and kidney is sort of 8th or 9th in the list in many of these studies. So maybe we need to advocate to make sure kidney function and proteinuria, simple measures that can easily be checked, are really prioritized and analyzed correctly in some of the studies that are ongoing. And then again, the long-term follow-up is different in different places, but I think it is being led by respiratory follow-up in many places. That's how it's happening sort of in our hospital. So again, I think our job there is to make sure that our guidelines for AKI follow-up, from what we know at the moment, are introduced into those post-COVID follow-up clinics. And I think the point that's really important is in patients who've lost muscle mass. If we're relying just on a serum creatinine-based estimated GFR, we're going to miss some patients who've got sustained reductions in kidney function after this. So that will need longer follow-up and ideally more sophisticated ways of measuring eGFR. But the sort of the ERA registry that you described already, that's focusing on end-stage kidney patients, but maybe we need some registries looking at AKI too, because it's not easy to do this on a single center basis because you don't have the numbers. We need to have some collaborative efforts, I think, if we're really going to.
I fully agree there, Nick, but it's quite difficult to organize this kind of long-term follow-up.
Yeah.
And let me interrupt you also with questions from the audience. One of the important questions is, do your data also suggest any consequences for management of COVID-19? For instance, you mentioned that we perhaps were running patients too dry initially. Can you give us some clues there?
Yeah, so we didn't specifically look at that, and we weren't able to do that in great granularity, sort of looking at a larger hospital-wide data set. So I think it's more anecdotal messages that we've got there, but I think, Eric, you might want to come in on this, but I think that there was a very strong signal at the beginning to run patients dry, to try and improve or preserve their respiratory function. And I don't think it had much effect or benefit, but I do think it did drive AKI in that situation. So I think that is one factor that's changed. There's big changes in terms of the ventilation practices that we're seeing. So there seems to be more CPAP now, and CPAP earlier in, so extending into the ICU admission. And again, there's controversy about how long you keep people on CPAP and whether that's always a good or bad thing. But that very strong link between the introduction of mechanical ventilation and the development of AKI, so the effects of a high PEEP and increased venous pressure, changing perfusion of the kidney, all of those things may link in there.
And some of people also questioned, might it have to do with the hypercoagulable state that you mentioned? And is the fact that we perhaps are now using more anticoagulants helping to decrease the incidence of acute kidney injury?
Yeah, that's also a very interesting question. I'm very nervous that I'm going to step on Tobias's toes here by talking too much about causes, but no specific data about that. Hard to look at in humans, and just as a sort of a flag of some of the research that we're trying to get into, it's we've been using some MRI methods to look at different aspects of kidney structure and function. And a group in Sweden managed to do MRI in intubated patients with COVID during their acute illness. So looking for sort of vascular changes and maybe sort of microthrombi at the time of AKI, I think imaging is the only way that can do that in a clinical setting.
Okay, I think because of the sake of time, we'll move on to the second presentation. And I know there are many questions related to your presentation, Nick, that also touch upon Tobias's presentation. So I think that after Tobias' presentation, we will have more time for discussion. So some of the questions that were raised by the audience, we can deal thereafter, and then you can pop in again during the discussion there. Luuk?
I agree, Ron. I also saw a lot of questions about what are the causes, indeed, of coronavirus associated acute kidney injury. And I'm very happy that we have two specialists who might try to answer this question. The first one is Professor Tobias Huber, who is chair of the Center for Internal Medicine in Hamburg. And he has published quite recently also some very interesting papers on the pathogenesis of coronavirus-associated nephropathy, as some people call it. After his presentation, we have Bjorn Meijers as a panelist. He is a nephrologist and associate professor of medicine in the University Hospital and Catholic University in Louvain. And we look very much forward to the presentation of Tobias Huber. Please go ahead.
Okay, so I hope everybody can see the screen and see myself as well. And I would like to thank ERACODA for organizing these e-seminars. I would like to thank Luuk and Ron for putting together this very interesting COVID-19 series. And I would like to thank Nick Selby for the great first presentation, and also for our great panelists and the discussion, and all of you across Europe for joining in and discussion and watching and being together with all of us. Now, I'm supposed to talk about now the mechanisms, and these are my disclosures. And I think, you know, all the epidemiology has been presented so nicely by Nick that I'm just very quickly using this as an intro. But I think during the first wave, we all recognized how important the kidney became, how often acute kidney injury was observed, and that many hospitals were running short in dialysis machines, more than even in ventilators. And all this, as we have seen so nicely by Nick's presentation, is now being summarized for first and second wave where a quite high number of AKI could be observed, between 30 and 40%, higher in the first wave than the second wave, and Nick has just been introducing some of the reasons. So, but as we have heard before, so acute kidney injury after lungs is the most prominent organ failure, and it really determines the cause of COVID-19 patients. And as also seen before by publication of Nick Selby's team, but also other publications confirmed that it seems that the rate of AKI and the need of dialysis is even higher in COVID-associated septic and severe illness diseases than other diseases, while this is of course being done with historic controls and obvious shortcomings of such studies. So basically all this led to the hypothesis that we thought we need to look, what is SARS-CoV-2 doing beyond the lung? So what's this virus doing to the body? Is it being seen in other organs? Can it be detected in the kidney? And does this eventually contribute to a course of disease? Now, these studies that we then did in Hamburg were made possible by our Department of Legal Medicine, and together with the health governance in the state of Hamburg, it was decided that every person that died by COVID during the first wave received an autopsy. So that's why we had the chance to look throughout the body and throughout all organs, and to study the virus throughout the body beyond the lung. Now, this first publication was mainly led by Victor Puelles and by other people in the lab, Maya Lindenmeyer, and also from the Department of Microbiology, Intensive Care Unit, and of course legal medicine and other teams at the UKE. Altogether, there was 7 departments and institutes being involved. Now, what we did at the time was one of the largest autopsy series of 27 patients. All had severe lung COVID-19 disease, all died, unfortunately, by COVID. All of these patients, as you can see here, had many comorbidities, on average more than 3 severe comorbidities, including lung disease, chronic kidney disease, chronic metabolic diseases, or neurological diseases. And interestingly, when we then looked throughout the organs, where we looked by PCR and other techniques, which I will entertain in a minute, whether virus can be detected, it became clear the higher the number of comorbidities in these patients, in the more organs we could detect SARS-CoV-2. More specifically, while we had the highest rate of RNA copy numbers of this virus per cell, this is how we broke it down statistically in the lung, it was found also in relatively high numbers in kidney, liver, heart, much lower in brain and blood. So for us as nephrologists, it was interesting that next to a respiratory system, the kidney was the system with the second highest numbers. Now, this, maybe to sum this up, so this led us then to kind of speculate that this virus is not just a respiratory virus, but that this virus is a multi-organ virus, at least being found in other organs and potentially infecting other organs. Now, of course, the question was then, why is the kidney eventually the second most affected organ? And from SARS-CoV-1, it was already known that there are certain receptors for SARS-CoV-2, while there might be other receptors or co-receptors as well. It's clear that ACE2 is a key receptor for adhesion of a virus and for bringing a virus into a cell, and that this receptor itself is being modified by membrane-bound proteases that can further facilitate the absorption of the virus. And these SARS-CoV-2 adhesion and facilitator genes are being expressed in the kidney, as shown by single cell data in fetal and adult kidney throughout many tissues and cells. There's a slight variation between different data sets, and keep in mind that in particular single cell data sets have not such a high a sensitivity for detecting RNAs because it's from very small amount, just from one single cell. So that's why there's always some variability between different data sets of single cells. Now, what's very important, if you want to be sure that virus can be found in tissue, we need to detect it with different methods. So the first one was PCR, which was very clear. Then we established in cytohybridization techniques, and here we could see virus as positive control in the lung, and also in PCR positive kidneys, in glomerular tissue, but mainly in tubular tissue. Next, we established immunofluorescence, so to not only detect RNA, but also protein of the virus. And again, positive controls in lung tissue. And then it could be seen mainly in the tubulus, but we could also detect virus in different glomerular compartments like endothelial cells, and eventually also in podocytes. We next use different techniques and tissue microdissection techniques to look at different techniques. And then we could also, again, confirm virus in glomerular tissue, which might have a connection to this glomerular disease that had been observed in a few case reports, namely collapsing proteinuric nephrotic range, collapsing glomerulopathy, FSGS, in COVID-19 patients, is also very recently being published in 6 cases. Now, let me summarize this first study. And please keep in mind, the study was done in most severe critically ill patients that died, that deceased by COVID-19. So this patient cohort is not representative for normal symptomatic patients. But in these patients, we clearly could redefine SARS-CoV-2 as a multi-organ affecting virus. We found that next to respiratory, kidneys are the most infected organs, and comorbidities associated with this renal and multi-organ tropism. Now, this might be one part of the explanation for the many symptoms we see throughout all organ systems, including neurological system, gastrointestinal system, kidney system, and many other organs, that the virus might also be directly affecting these organ systems. Now, of course, this led to a second question hypothesis. So is this SARS-CoV-2 tropism in the kidney associated with organ outcome? And this was the second study that we then published. And again, it was mainly executed and done by many people from across many departments, as shown here, and then led by Fabian Braun and people from microbiology and Victor Poelis and people from legal medicine. Now, here again, at the time, it was one of the largest autopsy studies, including now 63 consecutive cases from the first wave. Again, you can appreciate and see here that these people had a high rate of comorbidities, on average 3.3, and like in the first study, in 60% we could detect the virus in kidneys, and this detection was associated with higher aged people with a number of comorbidity and slightly favored by male sex. Our first finding was that when we looked from the time of infection to the time of death, that there was a significant correlation of renal tropism to premature to earlier death. And the second, and this was the main question, that the rate of severe AKI and the need of dialysis was significantly higher, around 70% in patients where we could detect SARS-CoV-2 in the kidney, in contrast to roughly 40% in patients where we could not detect SARS-CoV-2 in the kidney. Now the question is, what does detection of virus mean in an organ? Is this just because the virus is being absorbed, endocytosed eventually, or is there also replication outside of a line? And this is a typical kind of like Koch-Lesch's postulate experiment where our microbiologist team used chunks of a kidney from a person decided by COVID-19, and it was highly positive, PCR positive for a virus, and then of the supernate of the kidney was being used to infect other cells, and then in these cells we saw a high replication of the virus, more than 1,000 times within 48 hours. So from here we could see and detect that live virus in fact can be retrieved from positive kidneys. So this is an indication that in some and probably rare cases, virus can potentially replicate in kidneys. To further substantiate these findings, we used a primate tubular cell line, non-human, infected it with SARS-CoV-2 and then stained for replicative proteins. And also here we could show that in these tubular cells, the virus is actively replicating. Let me summarize this second paper. And again, be aware, it's really a very particular patient cohort of patients that unfortunately died and were severely ill with severely COVID-19 pneumonia. But here we clearly saw that renal tropism associated with premature death, renal tropism associated with AKI. And we could show that SARS-CoV-2 can replicate in kidneys. And this might have implications also for long-term effects and outcomes as previously discussed. In summary to this story, I think what we heard by Nick Selby, and we should over-interpret this data. So by clearly virus is found in tubular cells and it can eventually, under certain circumstances, even replicate. Clinically, the strongest association to kidney failure and severe kidney failure are the symptoms of critical ill patients. So it's hemodynamics, is eventual microthromboembolisms, ischemia, and inflammatory systems. These are the main driving forces of AKI. However, we can also detect the virus, and it needs yet to be proven what the impact is, or the direct impact is of a direct viral infection and how much it contributes to these factors, which are certainly the main factors. Now, based on these data, together with Oliver Gross, we speculated that while the kidney is certainly affected by SARS-CoV-2, being a direct or indirect by cytokines, that urinary testing might be a good early marker for predicting the course of SARS-CoV-2. And that's published very early on, and at least submitted very early on in the first wave, this hypothesis paper that very simple urinary dipstick testing might be helpful. We could then, and it's not published yet, it's under revision, but we would like to share these data with you, again, led by Oliver Gross from Göttingen with Hamburg and other centers together. What we could see is that if people that are just, coming through the door to a hospital and that are being admitted and that are receiving a urinary dipstick, that this urinary dipstick, together with just two simple serum parameters, namely albumin and AT3, that we form the traffic light for risk, low risk, no urinary changes by dipstick, and then an intermediate group with changes, and then red group if there are even changes in these two simple serum parameters. Just please keep in mind, this was designed in March, so today we would probably design it differently. But then it turns now really out on these patients that if people have no urinary abnormalities, their risk of getting admitted to an ICU or receiving renal replacement therapy or dying is much lower than if they have urinary changes at the beginning, or even changes of these two serum parameters. And if you do it without the serum parameters, just the urine, again, we see this difference. So easily done urinary dipstick is an indication of the later course of a disease. So let me summarize the whole talk. I think what we studied was looking for SARS-CoV-2 distribution throughout the body. We could redefine SARS-CoV-2 as a multitropic virus, which can be found specifically in the kidney as almost second mostly affected organ, which might be part of the explanation for the many symptoms we see. Number one. Number two, SARS-CoV-2 renotropism associates with outcome and rate of AKI. But we are not claiming that this viral infection is a main cause of AKI. It's surely cytokines, hemodynamics, and critically ill patients, but maybe the virus has some modifying factor in it. And this was the news infused to one of our papers, also summarizing that virus can be found in different kidney compartments and might also eventually contribute to the glomerular phenotypes. And the third thing is that, as seen by a very nice previous talk, kidneys are affected early on. We see lots of urinary changes. They might correlate with the later outcome. I would like, this was to thank very quickly the people. It was a true collaborative work, people working day and night at our medical university center across all disciplines together. And from our side, it was mainly Fabian Braun, Victor Poelles, who was a professor for complex tissue analysis, Maya Lindenmeyer, Nicola Wanner, and all others. And with that, I'm looking forward to questions and discussions. Thank you all for listening.
Thank you very much, Tobias, for sharing this very interesting data. And I would like to invite Bjorn Meijers to start a discussion. Maybe he has some comments and questions to you.
Yes, thank you. Tobias, a wonderful presentation. Also a great set of experiments. A very recent editorial published in JASN about a week or so ago suggested that your work should be seen as the most prominent data really demonstrating kidney tropism. So fantastic. Still, there are many questions. As with every bit of good science, there are more questions than answers. As you already showed, the expression in adult kidney of the ACE2 receptor is much higher in tubular cells than in glomeruli. And some would even say, although this is based on next generation sequencing, you already mentioned it, that there is hardly any expression of ACE2 receptor in glomerular tissue. Yet, if you look at the clinical data, also in those patients that do not develop AKI, so with only proteinuria and hematuria, the actual percentages of hematuria and proteinuria are more or less equal. You see this in about 40 to 50% of all patients that were demonstrated as having COVID-19. How can we explain this? And well, are we looking at glomerular proteinuria or tubular proteinuria? What can you say about this?
Thank you, Bjorn. This is an excellent question, and it really helps myself to explain a bit better, because we've been put a little bit in a position of people saying it's all direct viral infection in the kidney. And what we really could show, and I think it's helped nephrology, yes, the virus can be found in the kidney. Yes, we need to look at the kidney. However, pathophysiology is much more complex. As Nick was showing, the main factors are the systemic factors. Systemic inflammation, systemic hemodynamic changes. These are the driving factors of the kidney disease. That's why I wouldn't call it COVID-19 nephropathy or something, because it's mainly, I think, systemic factors. Now, coming more specifically to your question, we see virus in the kidney, but again, keep in mind, our cohort is very specific and not representative of a normal person walking in the hospital and working out of the hospital. It's really the people with the highest virus replication in the lungs that died by the virus. So this is not representative. This is the second limitation. So what I think, most urinary changes that we see in so many patients are being caused by the inflammatory status and by eventually hemodynamic changes. And there will be cumular as well as tubular. I think most of it, that's why we see so often proteinuria, most of it is being caused by tubular proteinuria and tubular affection, much less by cumular proteinuria. And then we see these few cases with nephrotic syndrome range proteinuria and collapsing FSGS. And again, here, I think it's really that the disease probably shifts the threshold of somebody who might have a genetic susceptibility like APOL1. And if you then have this inflammatory status that lifts the threshold to disease, and whether or not direct virus in the podocytes, for example, plays a role or not, cannot be shown yet. Probably it's not the main driving factor. In tubule cells, we're going to show very soon also that we see interferon response and some inflammatory response. So there it might really have a contribution factor. In podocytes, we might see, especially in the endothelial cells, where we also see the virus in the cumulus.
Mm-hmm. Still, it's a bit surprising that you see this high incidence of proteinuria and also in non-critically ill patients where I think that the cytokine storm is much less outspoken or even not even present. So there must be other factors that explain this tubular proteinuria. From a more pathophysiological point of view, if you look at the localization of the ACE2 receptor in tubular cells, at least in non-stressed individuals, it's mainly located at the apical site. So there's a polar expression facing the tubular lumen. And so how then would viral particles enter the tubular cells? If the ACE receptor is only present at the tubular lumen, this would imply that the virus is in the tubular lumen and thus also might end up in the urine. And actually, we don't have much evidence in support of that.
Yes, very good question. And so I think there could be three explanations. Number one, it might be coming from the urinary side, and while most studies didn't find virus in the urine, there are some also showing it by proteomics, so it's not solved the question, and maybe many of this is being reabsorbed. Alternative number one. Number two, it might come in fact from the basolateral side, and there it might, some of the virus that we see in the kidney might be just uptaken by macropinocytosis, by endocytosis, and might not be actively replicating virus, right? This is nothing that we can distinguish very well now in all the single tissue studies. So this might be the second explanation. So some of this might be just virus, in what we see virus in the tubule because of passive uptake, like macroendocytosis. Some of it might be coming actively from the tubular side, while very little virus is found in urine. And some of it might even be coming also actively from the basolateral side. And keep in mind, we are also fixated on ACE2, but we also learned that, even in the cells where we know that are being infected, that there's no strict correlation of ACE2 expression and virus in these cells. So maybe there are also other receptors or co-receptors that are bringing SARS-CoV-2 in the cell, which has not been finally solved yet. Just to entertain to keep our minds open for alternative explanations.
Okay.
Thank you very much, Tobias and Bjorn. May I interrupt to give the audience also the opportunity to ask burning questions?
Yeah, that I was trying to do. But there was a question from the audience saying, how mechanistically might dexamethasone be reducing AKI risk so substantially? And this goes to the heart of the question: what is the driving force? Is it kidney tropism, or is it the cytokine storm that is actually causing this trouble? So can we learn something from intervention trials and the dexamethasone?
Thank you for the question. Let us all agree that the main driving force is the systemic factors: cytokines, inflammation, hemodynamic factors. This prevents, us from, because otherwise we would overstate, while we published them well, and I think these data are very important, but we do not want to overestimate the data, right? Virus can be there, it will contribute. The main, and this is a good argument, this is almost a proof of concept that if you lower systemic inflammation with dexamethasone, you have a better outcome of patients in terms of ventilation, COVID-19 pneumonia, and so on and so forth, then you have less kidney disease and AKI. This itself is a strong argument how important the systemic factors are for AKI, right? And I don't think that dexamethasone itself impacts renal tropism.
Question that was related to this issue was, and that I think it's a very interesting question, is can there be different phases in the disease? Nick Selby showed us that we have several peaks in the incidence of AKI, and could it be that the different mechanisms play a role at different time points in the course of the disease?
This is an excellent question, and I think it very well could be, and also with renal tropism. So it could play, you know, maybe in this later phases more role than the first phase, and it could also play a role. You know, if it plays a role, it could play a role maybe in the long-term outcome. Because what we see in these epithelial cells that are having the virus, they shift itself to a more pro-inflammatory status. So they might very well, tubular cells might very well produce factors that drive the tubular interstitium at low rates to more fibrosis. So that's why I think what was discussed before, also in the theme of long-term outcome and observation, it will be important for us as kidney community that we have a follow-up strategy for these patients.
And in your series, you had patients with different locations of the virus. So you showed that it was mostly present in the tubules, but also in podocytes. Were you able to correlate the clinical findings of these patients with the localization of the virus? So some people observed that there were patients with a massive amount of proteinuria. These the patients that had podocyte location.
Very good question. No, we weren't able, because none of our patients we looked at the 63 patients had a severe nephrotic syndrome. So these kind of collapsing FSGS patients are more rare. We didn't have any among our cohort, so the clinical kidney phenotype was quite similar. That's why we couldn't make a correlation. But I can tell you, in the people who develop collapsing FSGS, only very few could identify virus in the podocyte. While many, I saw a correlation to APOL1s. What I think is APOL1 carrier have a very much increased susceptibility to inflammatory changes. It could be SU, or it could be many things that are up in SARS-CoV-2 or COVID, and they push basically then this collapsing FSGS disease under a certain genetic background. Again here, I don't think that the podocyte tropism is a driving force, but this is really something that we're going to look at in follow-up studies.
Okay. Ron, you would like to pose a question?
Yes, because I was very struck by Nick showing data about the second wave and suggesting that we had improved outcome, perhaps via the treatments that we are giving. But I'm not really convinced yet that outcome is really better, because I have the suggestion, but I'm not sure, that we are seeing a different type of patients at the moment, that they are younger, have less comorbidity, because the most vulnerable people are shielding themselves. So when we are comparing outcome now with the first wave, is it a good comparison, or should we adjust, or what can we learn there?
Nick, do you want to?
Yeah, thank you. I mean, I think that's a complicated question, and I think there's going to be a complicated answer to that, because I think there's the disease and then there's the treatment of the disease. There's the different baseline population characteristics, and then on top of that, there's even more complicated things in terms of the pathways within hospitals have changed. So in the first wave, for example, the pressure and the stretch on the provision of healthcare was much greater than it is now. So maybe that had an impact on how care was delivered. So it's going to be impossible to tease out all of those things. So I think they're all totally valid points. And I think probably if we're seeing better outcomes now, it's not going to be a one single answer that explains that. It's all of these factors that we've sort of raised coming together, and it's a complicated situation.
Mm-hmm. Thank you. And maybe one of the last questions, Bjorn, we would like to know what is going on in the kidney. And Tobias showed us what is going on in people who are diseased.
Yes.
Would you be interested to do biopsies in the patients who present with COVID-19 and acute kidney injury? And maybe the same question for Tobias.
Yeah, that's a question that also came from the audience, and evidently, as a nephrologist, when we see proteinuria, we're tempted to put in a needle and do a kidney biopsy. However, we learned from some other virus-associated nephropathies, such as pulmonary hantavirus-associated nephropathy, that the proteinuria might be temporary. So we just, if we're sure of the diagnosis, we wait there. And only if we have a differential diagnosis that needs to be solved, then we do a kidney biopsy. And in reality, I think that not all patients having had proteinuria were biopsied during a second, especially during the first wave. Most of them were not, actually, and we still have to look at long-term outcomes. But in those patients, proteinuria at least disappeared in the majority. So I would not do a biopsy in isolated proteinuria or hematuria, but if there is unexplained loss of kidney function, yes, we can do a kidney biopsy.
Tobias, your final comments on this issue?
Yeah, I think I agree with Bjorn, but there are a few cases where we should do it because we are learning from it. If a risk is acceptable, many people now are being, have more anticoagulation than before, which makes it a bit more difficult. But we are actually able, and we did it in a few transplant patients with COVID-19 associated kidney functional decline, and then we also could really detect the virus in the kidney. Again, a special case with lower immune system. So I think we can learn from this. Whenever we can do it, we should do it when it's reasonable and the risk is acceptable.
Okay, thank you very much. I would like to thank all the speakers and panelists again. Time is nearly over now, so I would like to conclude with some final remarks. We learned that COVID-19 and the kidney are closely interrelated, and today we focused on acute kidney injury as a consequence of COVID-19. But we also have to realize that chronic kidney disease is an important risk factor for severe COVID-19. There are data that the hazard rate for mortality is very much increased in patients with chronic kidney disease, and especially patients on dialysis or living with a kidney transplant. And that's the reason why the ERA-EDTA Council and the ERACODA working group wrote a kind of a position paper and also as a kind of wake-up call for action by the European Renal Association to do much research on this topic, of course, but also, for example, to emphasize the importance of including patients with kidney failure in vaccination programs and in studies on the efficacy of vaccination. So the next slide, please. And I would also like to take the opportunity to draw your attention to the ERACODA initiative again. Many of the people in the audience will have contributed to this database already, so I also have the opportunity to thank them for that here from this position. Ron in the introduction already said that we have now more than 22,200 patients included in the database, and of course it remains very important to add new patients with COVID-19 to get the answers to the important questions that we still have. So I would invite everyone to visit the website where you can find the information that is needed for you. And in the end, it is all for the sake of your patients. So then I would like to conclude with mentioning all our collaborators and the people who have done important work for ERACODA. Of course, the working group, the management team, the advisory board, all the collaborators who entered the data in the database, and last but not least, also our sponsors who gave financial support to make this possible. And with this, I would like the e-seminar of today, and again, drawing your attention to the third one in the series, which will take place at December 17, on more practical issues of how to organize your dialysis unit, and on renal replacement therapy in patients with severe COVID-19. And we hope to see you again in 2 weeks. Have a nice evening.